welcome to our second webinar in the Heart Talk series at Phoenix Children's Hospital. My name is Stephanie Starks, and I'm very happy to be your host today. My daughter was diagnosed with a critical complex heart defect, and I now serve as a parent volunteer at Phoenix Children's Hospital. If you missed our last webinar about heart catheterizations, it is now available on the Phoenix Children's Hospital website on the heart catheterization page. Today, I'm grateful to present clinical nurse education specialist, Michelle Osborn. Michelle has 34 years of nursing experience working in intensive care, specializing in cardiac intensive care, helping families and educating nurses. She's joining us today to educate us on basic cardiac care. Basically, she's going to explain what all these machines, tubes, and wires are doing on your child and empower us to ask the right questions of our care team and help us feel more confident taking care of our children. I have a couple of housekeeping items to cover quickly before we get started. We would love to hear from you. You may submit a question at any time during the webinar using the Ask a Question button, and Michelle will be happy to answer you at the end of today's webinar. You will also receive a short survey after today's webinar, and your feedback is invaluable, so please take a minute to fill that out as well. This webinar will be available on the Phoenix Children's Hospital website later within the next few days, and we'd love for you to share this with your friends. Our goal is to educate and empower all patients with CHD and their families, but we can't do it alone. And now, without further ado, it is my pleasure to introduce Michelle Osborn.
All right, thank you, Stephanie. So I'm here to talk to you guys about the bits and pieces of all the accessories your child is wearing within the CVICU. So we add lots of pieces for us to monitor different components. The base piece you'll always see is your thought to be room television set. Actually, the television set is in a different location. It is this way, but this is the television set many of family watches. Okay, so this is your cardiac monitor is what we call it. So within the cardiac monitor, what we're really trying to see is a snapshot of how the patient is doing or how your baby is doing. We're looking at a snapshot. I can tell a lot as a nurse when I walk into a room looking at the child and looking at the monitor. I can get a good snapshot of where we are today and what's going on. Okay, so when we look at the monitor, the first thing we all look at is the ECG or the electrocardiogram. That's the heart rhythm. Okay, this is the one here in green. So when we look at the heart rhythm, what we're looking for is how fast is the heart beating? Is that a good rate for that baby or not? Is that a reason why, or is it beating too fast or is it beating too slow? Because as we look at those pieces, we want to see then how is the baby's cardiac function or how are they looking? Do they look good with this amount of heart rhythm? When you're angry, your heart rate goes up and you cry. When you're asleep, your heart rate should come down because it's as your body needs, it will go up and down. Actually, we even have an equation, very simple one. Cardiac output is heart rate times stroke volume, which means how much the heart squeezes each beat. So if the heart isn't squeezing very well, the rate will go up, okay? And we'll go faster to try to meet those needs and equal that equation. There's components of the heart rhythm we also look at too. There's components of the chambers of the heart and are they firing correctly? So we're looking at electrically through the little patches on the chest. I'm sure many of you have seen it on television and seen it other places. So those little patches look at the heart rhythm through the heart. So in different areas of different leads, we call them, we can actually look at the heart up this way, or we could look at the heart down this way. So sometimes you might see things turned upside down or in other ways, and it's still okay. The biggest number when you look at it is you're going to look at the rate, how fast. And is that a normal rate for my baby? Those are things you could ask your nurse, right? Is that a good heart rate? Is that where we want to be? Does that make sense? And those are the pieces we put together. Then we like to see the components. The first, the little wave in front of each tall wave. The little wave shows the top two chambers of the heart fired and emptied into the bottom two chambers. You want that to happen because up to 30% of the blood the heart's going to push around happens with that fill. The top has to squeeze to fill the bottom, so then the bottom can squeeze out. The second is then the bottom two chambers or the ventricles. So if the ventricles are firing and they fire together, you'll see this nice tall waveform that's thin. Okay, so you want a nice, what I call it is nice and tight. So we call it the QRS. So it's nice and tight. That means the ventricle is squeezed. That's what you get when you feel for a pulse, is the ventricle squeezing and giving blood out. I'll tell nurses, actually, when you look at it, is think about your ventricles as other parts of your body, right? So as we age, parts of our bodies grow wider. Not parts we want, right? So I think of it as your buns, right? Squeeze your buns together, right? That's what we want, nice and tight. We want both ventricles to fire together and squeeze the blood out. If one ventricle goes before the other, it'll get wider. It's inefficient, okay? So that's where we have problems. So sometimes when your baby has a wide QRS, it's like, what's going on? It makes us worry. Can you be that way? Yes, but it starts to limit you of what you can do and how much things happen. So wider QRSs can even happen with pacemakers, because when we put a new pacemaker and we're making the bottom two chambers squeeze, a lot of times we only put it on one chamber. So what happens is as it goes over, it's wider because it goes one, then two. So we want so the goal is always to make things squeeze together. So we'll look for those components and we'll say, all right, there's our heart rhythm. Not a bad heart rhythm for a newborn baby. 114 means you're sound asleep and you're in pretty good shape, because 114 is a nice heart rate. 120 to 150 in a newborn is very common, where I'd like to see it. Think about when you exercise, when you think of heart rate. I don't know if any of you have done, some of those high intensity interval training, such as Orange Theory. Okay, so in Orange Theory, they push you to push your heart rate up, right? So as you push your heart rate up, mattering on how good a shape you're in, matters how you tolerate it, right? So you might say, oh my gosh, I'm getting dizzy, right? I'm nauseated. I wish I could stop just to see if I had to pee, right? Because you could get off and say, I got a reason to be out of here. So that's stress, right? For your babies, that's eating. Okay, so as they nipple feed, that's their interval training. So sometimes you might notice they breathe harder, they sweat, and their heart rate goes up because that's their intervals. Can they tolerate it? Can they eat? Is their gut getting enough flow, right, for them to feel good? So we'll watch heart rate go up and down and say, how does the baby look? And does it come down? So same with interval training. You go up, the goal is you recover. Right? I can burst and I can come back down, and then can come back down nice and easy. Now, in some of our sick babies, that doesn't happen. So that's why we know something's wrong. So that's where heart rhythm helps us there also. Like your baby was screaming, his heart rate was 180. He stopped crying, went to sleep, heart rate dropped to 140. He could handle 180. Now your baby was 180 and it didn't come down when they were sleeping. It didn't come down when we treated a fever. All those things start to make us concerned. Okay, why is the heart rate so high? Other things we'll look at is blood pressure. So this is a continuous blood pressure reading off of what is called an arterial line. So an arterial line is actually stuck frequently in the radius, so you'll feel your pulse on your hand, and we'll stick a special IV catheter there and hook it up to a monitor that can read the pressure differential. So you'll see actually the nurse be what she calls zeroing. What she's doing is turning it and making it open to atmosphere, saying that's 0. So when I turn this, what pressure do I feel? Okay, and that reads blood pressure. So it's a very nice line for us to continually say, okay, heart rate's this, blood pressure's this. Where are we at with everything else? And we'll look at the breathing rate. How fast is the baby breathing? How hard are they working to breathe? Because that's a big deal, is if you're working very hard to breathe, everything else is stressed, right? So we need to figure out, why are you working hard to breathe? How can we make that easier? You may get blood pressure on the arterial line, or also we could use a blood pressure cuff. I'm sure many of you have had your blood pressure taken at the doctor's office. Your baby will wear a little blood pressure cuff. It'll go on and squeeze up and then let a blood pressure come down. So blood pressure cuff is another way we can watch blood pressure and how are you doing. One other component on here is something a little more advanced called an end tidal CO2. So when you breathe, you take a breath and the heart and the lungs are connected, right? So the heart's job is to get blood to the lungs so that the lungs can then exchange, right? So what happens is the heart brings the blood to the lungs. There's carbon dioxide from the body exhaling into the blood. So that carbon dioxide goes across into the lung to say, okay, exit the body through the breathing. What also happens there is oxygen's there. So oxygen is picked up by the blood and then gone back to the heart to turn it around. So end-tidal CO2 says how much is the baby exhaling, how much carbon dioxide is coming out, and it can let us gauge how well they're breathing and what's going on. Is there enough flow? All those components. So end-tidal CO2 is a great number. You may have actually utilized it if anybody got a tooth pulled. You ever get a tooth pulled, all right? And they put a little nasal cannula in your nose. And they're actually, because they're sedating you, watching your breathing through that little cannula, it actually is saying how much carbon dioxide, meaning if I give you too much drugs, you're not going to breathe as fast, and so that number would go up. So those are what we're watching for. It also shows us how the ventilator is doing. So those are the base components of the monitor. I do encourage you not to stare at it continuously and don't always get caught up in the exact moment what's going on. Yes, it will alarm at times. Why it alarms is we set limits to let us know. Sometimes it might bounce a limit, it lets us know, but then everything got better. The nurse actually gets a notification on the voice box she's wearing, the Vocera. It'll actually click saying something went off. Are you okay? And the nurse can look and say, yes, I'm okay. She can also pull up, if she has a second patient, she can actually watch those numbers in the other room. So she can watch both patients at once, even when she's not physically there. And then we also have central areas so that someone doesn't always run to an alarm. Many times it's because it's already converted itself and it's okay, and she was in the middle of something, so she didn't run right then. Other ones will go higher and higher levels if they're somebody needs to answer them right away. So monitors do ring, and it's because we set them up to ring. And so we have to be, sometimes somebody might set it real close and you might bounce things a lot. So you have to be very careful with that. One other reading which is on here is also then your SpO2 or pulse oximeter. So a pulse oximeter, what it is a little light that you wear on your finger. I know I'm probably dating myself, but if any of you saw the classic movie E.T., he had a finger that glowed, right? We always thought of that back, well, now it's so 90s, 2000. But you might see his finger glowing. That's what we're doing, we're putting a light. So what that light reads is the amount of oxygen on the red cells, the trucks, the people delivering oxygen in the red blood cells. And it sees how many of them are carrying an oxygen molecule. Okay, so many of you may go home with one of these monitors. So what that shows is how much the heart is sending out. Okay, so that's pulse oximetry. If your baby has blue heart disease, we know they're going to be a little blue. Like mine should be 98. I live in Phoenix. Now, if I was at altitude, it actually is a little lower. Like in Denver, the number is actually more like 88 because they're at altitude. So altitude plays an effect. We're very close to sea level. So those of you who live in Prescott or live at a higher altitude, where your pulse ox reads is different, because actually what happens is as you go up in altitude, the pressure in the lungs changes. I don't know if anybody's scuba dived before. When you scuba dive, you're very careful about that pressure in the lungs. So as that pressure increases, there's a different capability of pulling up that oxygen molecule, and so it's accepted to be a little lower. In blue heart disease, we know that the two amounts are mixing. Okay, so as they mix, then we get where we say, okay, this is an okay number because you're mixing and we want you to mix, okay? We want to have enough blood to go to each system. So your physician team will actually tell you what number you want to be at, and we'll let you know when to worry, okay, and what the worry amount is. Now, when we look at a patient, we also then look at how are they doing? What's good cardiac function? You're like, okay, how do I know my baby's doing well? Guess what? It's not always just this, okay? So don't let this control you. It's actually your baby's a person, okay? And in a person, you touch them and you feel them and you know that things are better. So when your baby's a person, the biggest assessment I could do is this, my plastic baby, so he's not a person, but I can feel your foot. So if your foot is nice and warm, you have good perfusion, okay? So you're getting blood from the top to the bottom. You're doing a good job, all right? So perfusion is big. So if your foot is cold, then the next thing I'm gonna do is your leg cold? Is your knee cold? Is your calf cold? And do you have a fever and all this heat in the center, okay? Because you're clamping down everything. So it makes it harder on the heart, actually. As you clamp, it has to push against resistance. So The warmth of the leg, the warmth of being able to take the heat from the middle and put it out is how we show good cardiac function. We'll also feel for what we call pulses, which meaning we can feel the pulse just like in your wrist. We can feel it in their foot. So we'll feel for the pulse. Can we feel the blood getting there? That's all the blood getting there, all right? Other things we check is, remember those things I talked about when I was working out, my heart rate was really high and I wanted to do or I didn't feel good? So when you don't have good cardiac function, what your body does is it steals from the places it considers not as essential. What is not as essential? Your feet. It clamps your feet down so your feet get cold, right? Your legs get cold. Have you ever been sick? When you're sick, you get cold, you're clammy. All of that is cardiac function, okay? So the legs, the warmth of the perfusion, we're always into, do you feel warm? Now, is it a blanket warm? Not a blanket doesn't always cure this, okay? This is, can I get blood there? So covering the baby isn't always the reason, because sometimes what happens, remember I said the heat was in the middle? You're like, but my baby has a fever. All right, they have a fever. What we need to do, but at fever, actually every degree centigrade, which is a little more than Fahrenheit, actually increases how hard the body works. So every degree of fever makes the body work harder. In a normal person, a little fever is good. It kills bacteria, it kills bad things. But in babies that have problems, changes are hard. Does that make sense? So you change it a little bit and they don't feel as good. Or do you ever on your little kids? I'm sure none of you have done this. But let's say your little 2-year-old's crying, right? Crying, Mom, I don't feel good, I don't feel good, I don't feel good. Can you lay on the couch and watch this movie? You're like, no, not that one. I don't want to watch that one. But they're laying there, they're crying. You're like, let's get you a little Tylenol first, right? To give them a little Tylenol, 30 minutes later, boom, they're running, right? You took the fever down, the metabolic rate went down, they have energy, okay? They feel better. So those kinds of things are the same in a heart kid, but the heart kid has a tighter edge, okay? A tighter edge that they can fall off because their body's doing everything it can, all right? So another thing we'll look at is pulse oximetry is how much going out, right? How much is the part is pumping every squeeze to send out. And as I say, you think of red cells, you think of little trucks, right? Delivering oxygen. All right. Then the other side is something we call NIRS, INVOS, whatever you want to call it. It's called regional oximetry. So that's this monitor right here. That's reading a 62 at this time to 81. All right. I have that probe currently on my arm, okay? So it's reading the perfusion to my left arm. And it says, okay, Michelle, perfusing pretty well. Because what it shows is the blood on the pulse ox went out at 98, the tissues used what it needed, and it's sending it back at 81. So it's saying I used 20% of what you sent, okay? It means you're doing good. You're doing real good. I'm sending enough and it's coming back full, okay? It's coming back like, okay, they didn't need all of it because we're sending enough. We're sending enough trucks, we're feeding. So we'll watch that number because we can watch then how our place is being perfused, okay? So continuously, it's really, really cool. So your kidneys are the first place to shut down because they're the waterworks. So the body says, hey, we need more fluid. Remember, because I talked about stroke and squeeze. So if we can't fill, I'm going to hold on to it to let it fill more, right? I'm not going to get rid of the fluid. So your kidneys open and close very consistent, very constantly all day long. So you'll see us do something that we call as renals, right? Or the renal NIRS. And what we're looking at is that venous side because the body eats the oxygen. First place is fed are your brain. So you might see a cerebral, we'll call it, and your heart. The heart one we measure actually drawing a test, a blood test, because we can't put a monitor on that in that direction. But other places we can look is we could look at guts and we could look at kidneys. So we'll put it on the kidney. It actually goes in the spot between the bottom of the ribs, top of the hips, not on the spine, right there. Okay, and it's right there, it can see this kidney, okay? So it says, hey, right now the kidney's being fed well. We're doing great, right? Oh, wait, you stressed Michelle out. Michelle went to Orange Theory. And she hasn't gone very often, and she's trying to get her heart rate, get orange. Oh my gosh, she's gonna puke, right? My kidneys, they're like, no flow for you, baby, no flow for you. We gotta get these muscles going, right? And so that me wanting to go pee, I really don't have to, but I just got to stop. So what the body's doing is I don't have enough flow for you right now, so I'm gonna clamp. So that number would go down. Does that make sense? Because it says you're not sending as many trucks, you're diverting them. Okay, so what you're delivering to me, I'm taking the little bit I can. So when you see NIRS drop, it's going to go up, down, up, down, up, down. We're looking at trends. Okay, where is it? How is it doing? How are we doing on the consistent? When I stop working out, or I stop eating, or I stop assessing your baby, right? Changing their diaper, or doing all these invasive things, I stop, does that number come back up and say, oh, getting enough flow now, we're not stressed, we're good. So that's what we'll watch with NIRS, is where are we? So what it should be is when the blood goes out, 75% should come back oxygenated. That's good. I consider that an A work, okay? Can you get a B? B might be in the 60s, 60%. Is a B, you're still doing good, right? And you got a C in school? I'm sure none of you did. I might have gotten one, but I just didn't go to that class. Didn't like it. So you get a C. Does it mean I didn't get a very high GPA, but I got a C in that class. I passed, I got a degree. So you can get Cs. That makes sense? Now, when we get low, when we're at 40% of what was sent out, you have to remember that, of what was sent out. So if your baby was 85% to start, it's 40% of 85, or 50% of 85, okay, versus 100. So when those go out, then you have some problems, okay? So that means we've got to do something to make it better. So that's why we'll watch that monitor very closely to see those changes and see those trends. Other things that we're going to talk about today is breathing, right? Making it easier to breathe. When you have heart failure, what happens is blood gets stuck in your lungs and they get wet. Your babies are on things called diuretics or vitamin Lasix, meaning everybody gets Lasix to help them pee, get rid of the extra fluid. When lungs are wet, you have a hard time breathing through them. You have to think of pulling through something hard, and as you pull, you retract is what we call it, meaning you can see bones, right? You can see the bones because the muscles are working hard. You can see everything pulling, the nose flaring, right? Trying to make it to breathe through the wetness or breathe through pneumonia. That'd be junk, right? Mucus. So things we'll do to try to make that better. You might see your child on something called high flow. When they're on high flow, it's a little nasal cannula that we put in the nose. It's giving air and oxygen. So it's a step above just a little nasal cannula that just gives a little oxygen. We'll use liters of flow. So to make it easier to breathe, what high flow is to me is kind of like your dog in the car. So your dog in the car, what does he like to do? He likes to put his head out the window, right? And, all right, that's what high flow is. Big breath, take a big breath, lots of air, slow down. That's what we want to do, slow down. So we'll turn the high flow up and down. The oxygen part is related to the pulse oximetry. The airflow part is to how hard is the baby breathing. If the high flow isn't enough, they say, no, I need more. We might move to something we call RAM cannula. Now that's something that what it does is actually attaches to the ventilator machine, but we don't have to place the tube in their throat, which is something that makes you choke. I don't know if you guys have some problems at the dentist. I do sometimes when they're in my mouth. You think this is in the back of their throat. So sometimes it can make them cough and make you uncomfortable. So what RAM does is actually gives little breaths, and it says, breathe with me, slow down, breathe with me, I'm giving you extra air, breathe, 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 versus breathe in 80 times, go 60, 40, breathe with me like a metronome. And so we'll utilize that to not put the breathing tube in. Bigger patients, I don't know if you know about people out there that are on something called, they have sleep apnea. Have you ever heard of sleep apnea? They wear what's called a BiPAP mask. What that is a mask on their face that's sealed. We're pushing air pressure in and letting them exhale and holding their lungs open, okay? We'll do that on babies that aren't breathing well or that have a lot of heart failure. Think of it as squeezing the water out of the lungs, and they'll actually look better on it. Even though it looks uncomfortable, you actually feel better. You can sleep better. Then the last thing we'll go to is the breathing machine or the ventilator. So this is the ventilator. Normally it is attached to this endotracheal tube that bypasses the vocal cord. So when you're on the ventilator, you cannot talk. If you hear a lot of noise and sound, the tube could be out of place. We have it hooked up currently to what we call a test lung. So it's giving breath, do you see that going up and down? It breathes in, and then the air comes out. So that's what we're doing. We're giving a breath and then exhale, breath, then exhale. How we turn it down is watching how much do you need. We'll actually watch on it, and you can see when you initiate a breath on this green line, you'll actually see a little purple spike, all right, that we have the baby's taking a breath. So we look at that compared to the carbon dioxide level. And if the carbon dioxide level is where we want, it says, hey, this baby can do more on their own. And we continue to turn it down until we can get rid of that tube. Because our goal is to get rid of that tube as soon as possible. Here at Phoenix Children's Hospital, actually our length of intubation times, meaning time on a ventilator, are actually very short. Many patients are on the ventilator on average less than 18 hours, okay? Some babies are on them very long, some are very, very short, okay? So that's the breathing. Next place is, as a parent, what's your role here in the cardiac ICU? What am I to do? You're like, I don't know what to do. I'm not sure. What is my piece? Many times you come exhausted. So first thing is take care of yourself, because you just bought people to care for your child and you need to trust them. So as we care for your child, remember that we have to build trust with each other, okay? That yes, each of us has a role. As a parent, you're here. I always would encourage you to look here before you look here, okay? Don't stare at this. Look at your baby. Are they comfortable? Are their feet warm? Are they peeing? All those things are great. Can I calm my baby? I don't know if I can touch them with these tubes. Actually, you can. Have your nurse work with you. You can hold, actually babies especially are very calm by kind of holding them tight, because they think about in utero, they were tight up little balls. So they actually, as they grow, you push out, but actually having them nice and tight and compressed makes them feel good. So sometimes they calm down just doing this and calming them down. Your role also is to start to replace us. So as nursing staff, our goal is to teach you, and then you're to replace me as you go home, that you understand a lot more than your friends do about what's going on with your baby, to the point they may not understand what you're talking about, or even your life, because your life has changed. But your role is to start knowing what I'm doing. So when I give a medicine, ask me what the medicine is. I'm supposed to tell you the medicine, but what are you on? You need to learn it, because guess what? Last couple of days, too much information. Okay, you can't control it. So over time, repeat, repeat, repeat. Many of you are in post-traumatic stress going through this. You just don't remember what was said. And you're like, nobody taught me that. Well, maybe they did, but you just didn't remember that piece, right? Because there was too much. So break it down. We actually have things called a journey board, and that journey board is actually to help you through your baby's stay. These are the things I need to learn, and these are the things I gotta know. Okay, I got that one. Now, do I have this one? Don't try to take it all in at the beginning. So you need to learn, and there's things to learn on newborn babies that are blue or complex, like Gemma, Stephanie's daughter. You need to learn how to do CPR just in case you want to know how. So we want you to go to that class. Guess what? Actually go to it early. Go to it early. Don't procrastinate, okay? Because that one, you don't want to worry about it when you're getting ready to get home. Get it done. Get it out of the way. Yes, I learned it, okay? And I can always review it. YouTube is a wonderful thing. You can review that. There's other just needed things you need to do. Learning the medicines, absolutely a key piece. For single ventricle kids or kids in these special interstage programs, you're going to go home with some of the monitors, okay? So you need to learn how to run them, like the pulse oximeter. Where's my baby's pulse oximetry supposed to be? When should I worry? What are they supposed to look like when they're breathing hard? What does breathing easy look like? What's warm? What do we want? How many times should they pee? All of those things are your keys. A lot of them have to be, for a newborn baby, also the biggest thing, and I know you're stressed, is actually to produce breast milk is amazing for your baby. Breast milk is huge. It's so much easier on their bellies. It's so much easier in many ways. Very hard to pump when you're like, but I can't do it right? And I just feel like a cow. And I'm sorry, but I don't feel right. I had to do it myself for my youngest son, and you do. You feel like in this weird purpose. But actually, you are providing a huge component to your baby's healing. A lot of our babies have decreased flow to their bellies. Breast milk is easier to digest. It's easier for them. They may not have as many issues with their bellies if you do breastfeed. So let us help you, but do that. It is important. Learning to hold your baby, learning to touch your baby, to be around your baby are huge components. Many parents are just so scared they can't be around them. Try over time to get closer, to hold them. Help us teach you how to pick them up. Help us know that you're ready and be here. We need you here, but we also need you sleeping. Okay, so if you're here 24/7, yeah, Stephanie did that. It's okay, but you'll go a little crazy. Okay, you will go, we call it ICU psychosis, okay, because you go a little crazy. You're only in this little world, right? And this is your main television set. The channels don't change that often. So go home, go sleep. If you have other children, take care of those other children, but make time that you learn also, because we don't want your baby's discharge to be delayed because you didn't do your learning yet, okay? Those are key pieces. Ways to get better and go home, exactly that. Take care of yourself. If you get sick, everybody has a virus at the house, we got a problem, right? We don't want the baby to get a virus. So you got to take care, keep them out of, keep viruses away. If everybody in the world wants to visit you and the baby in the hospital, careful who touches, careful who washes their hands, careful who's there, okay? Yes, they're good for support, but you may not want everybody touching, okay? The learn your pieces, how to take care of them, prepare your home, okay? Prepare your home that you're ready. And it's a big job. It's a big job you're taking on. We want to help you through it all the way. We are here for you, and we're here to make things better. And with your nurse, a lot of times your nurse might be super chatty, like maybe me, or you could have a nurse that's kind of quiet. The same, if you're a little scared of each other, start to break the ice, start to talk, both of you, start to say what's going on, or hey, what is that you're doing? I never seen that. Remember, everyone has styles, and people may get the same job done just a little differently. And remember, that's okay. Okay, it's hard to deal with sometimes when you're used to the same person doing the same thing every day and you love that person. That sometimes another person could come in and do the exact same things just a little differently, and your baby's still okay. And because if you get too hung up on that, you get stressed, you get mad, you lose a lot of energy. And just so you know, you're already exhausted, you lose, your edge is tight, you will fall off it really fast. And your family suffers. Remember that. You start snapping at everybody because you're tired, you're overwhelmed. Remember, you're snapping at your 2-year-old for doing something he always did. Okay, he always ran around. He was always having fun, but you're snappy because you're edgy. Okay, and you start snapping when you don't belong, and it's okay. And if you can forgive yourself, and even try to forgive the moment if it went wrong, he's like, hey, sorry, I was just really, really in a bad place. Or if somebody does something that really is wrong, let us know. We will work with them as our leadership team. We're going to work with that nurse and maybe build their relationship. Don't always, many times what we call it is a parent firing the nurse. So when you fire the nurse, sometimes you broke an edge. So if we can work out that we can get along, or what exactly the problem was, or was it just a crummy day and I don't feel comfortable going home, let the supervisor know, let the manager know, so we can help you and make it a better place. But also we have to all try to understand where each other's coming from. So if we can talk, it's a good thing. Okay, if we can talk about what's going on. All right, well, that's the basics for you today. I hope that was helpful. I am more than happy to do anything more advanced, and we can talk about those things. But if anyone has any questions, I'm here to answer.
Thank you, Michelle. Wonderful as always. We do have some questions for you.
Okay.
So let me start here. What can a parent expect their child to look like coming out of surgery?
Okay. As I said, your baby's very, what we call accessorized, or I call it accessorized, you know. So if it's your little girl, you're in trouble early, right? Because we've done lots of accessories that will replace in other ways. So they will come back from surgery, and as a newborn, many times in a bed like this. This bed is a heater and to warm them. Many times with a breathing machine and a tube in their throat. This monitor, you'll see one on their head and one on their kidney. Then in the center, you may not be able to see, but we would have an incision, usually right down the center, because what they do is go right through the sternum and open that bone, okay, to get inside, to get to the heart. That will all be closed if everything is good to close. Sometimes on big surgeries, there's a little bit of oozing, and how you want to think about it is this is a closed space. So sometimes he might leave the bone open to allow for a little swelling or a little bleeding that might happen and gather around the heart, and we don't want it to squeeze the heart so it can't pump. We call that tamponade. So he'll leave it open, and we may close the sternum another day, but it's closed on the skin. You'll have drainage tubes coming out to a little unit that used to bubble, but now it doesn't. It's called an atrium. It drains the fluid from the surgical area. So we want to get rid of that fluid, so those drainage tubes will be there. You'll see they'll have a little catheter to drain their urine, and then they'll have IV lines, all right? So you may have IV lines in the hands, that arterial line, and many times, especially on the smaller babies, you may see an IV that comes out of the chest wall. What that is actually a special IV into the first chamber of the heart, or the right atrium. The right atrium is an area that we can give medicines through. On some of your babies, this is more anatomy, but you have a tube that drains the head that's called the superior vena cava, and the drains the bottom called the inferior vena cava. Those of you who are single ventricles, those are very important tubes because you're going to use them. So we don't always want IVs sticking in them because we could possibly get a clot around the plastic and maybe lose that vessel. So they'll use this right atrial line to allow us to leave those vessels alone, because if you need cardiac caths or we need other IVs, we don't want to have those vessels clot off. So you'll have many IV lines, those tubings, and the baby will be wide open like this with lots of drainage things. We'll warm the baby. We're monitoring their temperature all the time. Sometimes we don't make them real warm the first night because there's some rhythms that happen when you're warm. So we'll control the temperature to not go into those rhythms. Actually, what happens is, remember the little P wave in front, the atria? It actually starts going behind the QRS. The junction fires is what we call it, the middle, and it fires faster. And so that's firing faster. And what we have to do is actually we give medicines to slow it down and get them in order. Or we actually might do something that we call, we'll have little pacer wires. We might actually pace the first chamber to get it in front. I think of it actually, I describe it as a marathon. Let's say this is two guys running, all right? P wave, junction, QRS, right? The junction goes faster and he passes him, okay? So now this guy's stuck on his edge, but he's not in front. Okay, so what we try to do is slow him down and get this one in front and get that cardiac output better. So we'll be monitoring all those things that first night.
So pretty much the child's not going to look the same.
No.
It's going to be a very different
lot of pieces, lot of attachments that will slowly go away. So as they go away, you're getting better. Remember that. As we de-accessorize, as we take things out, it means things are better. Okay. And you're moving forward. First thing usually is going to we try to get rid of the breathing tube. Then we'll try to get rid of the drainage tubes and the extra IV lines. Okay. And try to slowly get rid of the Foley or the urine drainage, because all those things have risks. So we want to get rid of them if we can and make sure everything, and also get you out of here. Especially bigger kids, biggest thing you need is up out of bed, moving and breathing, because if they don't, so pain's a thing. So pain. Nobody wants to see their kid in pain, right? But if we give medicines that your baby's laying there like that all the time, they're not taking good breaths. And if you don't take good breaths, your lungs actually collapse a little bit, and then they don't exchange how they should. So actually we want the lungs to open up. I don't know if any of you used after surgery those machines where you suck in and it goes up a little cylinder, call that an incentive spirometer, trying to pull open the lungs, right? Here in the hospital, to make a little older child, a toddler, do that, guess what? They're not going to know what you're saying. So you might use bubbles. To me, bubbles is a little weak. Okay, it's like, it's not the same as, right? Because I want pop, 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 everybody open up. So you know what you can do is actually crying. Wow. Crying is good because they open up their lungs, and their lungs are wide open and then can exchange. So I'm not saying continuous crying, but actually when you get them out of bed and you want them to walk and they say, no, 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 you're like, yes, 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 because you'll get better. Okay, they will get better. And so breathing is a big deal, and taking big breaths, moving. So you're always like, oh no, it's just better. They look like this. They're just laying there until they're all better, and you just think it's one big step, but it's not. It's got little stages. So the more you're out of bed, the more they're up sitting, they're up walking, all those things. Even though they're crying about it, they'll get stronger. So you need to do those kinds of things.
It's so hard. You're so right. It's so hard.
Actually, there's interesting literature out there that people are asking about pain control with the overuse of opioids and everything. You've heard that heard that in the news, that they're actually asking some medical professionals to back off because we're making you too comfortable, which makes you actually have addiction issues later. So there's a whole thing out there actually trying to ask hospitals to back off a little bit on saying, are you perfect? Was your baby perfect? Guess what? Being perfect may not have been where you want it to be. You actually don't get better sometimes when you're perfectly out of pain. Well, think about it, you're just going to lay there too, right? Yeah. All right, if I don't move, I feel okay. Those of you who had a C-section, I had one, right? I don't want to move. I don't want to go anywhere, but it got better.
That's true.
The belly works better. The gut works better. Everything works better.
That's a great perspective. Okay, so let's talk about the medications.
Okay.
What are some common post-op medications?
All right.
And this will probably be a webinar in itself.
All right, it is. But you have all your IV pumps. We don't have that set up today, but here's I don't know if you can see these, a couple of examples. They'll be attached to this tree of medications or medicines and fluids. Some of the common medicines are to help the heart function, right? So one is a drug that we call the golden drug of cardiac. It's called milrinone. Milrinone, what it does is, remember I said when you clamp down, it's hard for the blood to get out? It's something we actually call afterload, meaning the load to push out, okay? How hard? So if you have low afterload, you're warm. If you have high afterload, you're clamped. So milrinone, what it does is decreases that resistance. So it makes it easier for that heart that's not pumping as strong to get the blood out. It also helps the squeeze of the heart and helps it squeeze more efficiently. So it has a couple effects. We love that drug. Actually, patients who are on a lot of heart failure, maybe waiting for a cardiac transplant, they may be on that drug because it helps get more blood to their kidneys. It helps get more blood to their guts. It helps them be awake and feel better instead of exhausted all the time. Wow. So milrinone. Another drug you might be on is something called epinephrine. I don't know if you guys have all heard of epinephrine, fight or flight. Exactly what it's doing. It's kind of clamping a little bit, right, to get blood back, but it speeds up heart rate, but it also increases squeeze, right? It's going to help you squeeze harder. So we'll use epinephrine to help that heart squeeze, right, and help it be more efficient. So when low output, meaning cold, high heart rate, blood pressure's a little bit low, not peeing, all those things, we may use these drugs to help squeeze that heart a little bit more. You can see also other medicines, one to help them sleep. So there's one medicine called Precedex or dexatomidate. It's a beautiful drug. It's a beautiful drug because you can be comfortable. Baby, this is like the perfect drug for that 3-year-old that had a cardiac cath, right? You're like, yeah, how are they going to lay still and hold that leg, right? Yeah, right. You guys are all dreaming. So what it does is actually lets them lay still, but continue to breathe. So we don't need to, because a lot of our medicines decrease your breathing. Oh. So pain medicines decrease respiratory effort, like morphine and Versed and things like that. So with dexatomidate or Precedex, what it does is actually lets you just kind of hold still and you're comfortable and you're just kind of laying there and you're just comfy, right? So it's a nice drug, but it doesn't affect breathing, so we don't have to be on a breathing machine always. So we'll utilize that. Also decreases the amount of our narcotics, right, of the morphines, the Verseds, because too many of all of these things creates dependence, and we don't want to make your baby go through withdrawal, right? So too many drugs, we then have to get off the drugs. So dexatomidate is a great drug if you need to stay still. So those are some common ones. We have quite a few others. Okay. IV food called TPN. We have fluids just because you're not eating. We have other medicines that make it easier they actually dilate, so it helps the blood get out of the heart more easily. And we combine them all to get the effects we want.
Okay, thank you. Next, what are blood gases? I've heard them mentioned, but I don't understand what they are and how they're measured. Okay,
so a blood gas. Remember I talked about the lung and the air, the oxygen and CO2. So a blood gas measures, if it's an arterial gas, it's drawn out of that radius, right? Okay, so that's the blood sent out by the heart that reaches and makes the pulse, okay? So when I draw that, what I'm doing is looking at it. Okay, things I'm looking at is saturation, right? So you see it on the pulse ox, but you'll see it on the blood gas, right? So you'll see as it's saturated. Okay. We'll actually see how much oxygen is in the blood.
Oh,
okay.
Wow.
So we can measure that. Then we'll measure something called pH. So what pH is acid-base balance, right? So we want you to have the right amount of acid-base balance. I don't know if any of you use pH balanced shampoo. Acidic things are hard on your hair, hard on your skin. They're also hard on other organs in your body. Okay? So acid is bad. We don't want a lot of acid. So we use that. Too much carbon dioxide makes more acid. Does that make sense? Okay, so we want to control the carbon dioxide to get the acid levels right. So how are you breathing? So we'll look, is your body doing okay with that? Next thing we look at is the carbon dioxide level. How much is in the blood? Then other things we'll look at is actually the bicarbonate, so pH balancing, right? They may have ever taken like Tums or something, right, for the acid in your belly or acid reflux, so it controls that in your body. And those numbers all switch too. Like you might get a blood gas, not just for breathing, it might be because your baby has diarrhea. So when they have diarrhea, their butts are burning. It's actually their acid coming out of their bottoms. And so their acid-base balances get all messed up in diarrhea. So we'll look at that. Then we'll also look at a venous blood gas, which is drawn off of maybe that right atrial line.
Okay.
Now remember that looks at the other side. So that's what's coming back. Okay, so we sent it out, saturated at 98%. When it came back, was it only saturated at 40%? We didn't meet their needs, right? What's going on? How do we make it better? And one other thing we'll look at is something called lactic acid. Okay. Anybody remember when you work out in the burn, right? It's called anaerobic metabolism, right? So the cells are metabolizing without oxygen, okay? There's no oxygen, so it's going to eat itself, okay? It's going to chew on the muscles to make energy. Okay, but so what happens when it breaks down, it makes acid. Those of you, maybe your grandparents will know, Jane Fonda, Feel the Burn. That's lactic acid, like when your muscles are burning or when you worked out really hard and the next day you can't walk because you haven't been to the gym, so you decided to go to the gym, you did like a lot of squats. Tomorrow you can't even bend over, right? Right. Your legs are burning. That's lactic acid, okay? Because you brought acid into there, and so we'll look at their acid levels, meaning are we perfusing enough to clear the acid or is the baby making more acid? So those are things we'll look at with a blood gas.
Okay. So that goes into our next question then, what is an ART line? That's the arterial line.
Right, an ART line is a blood pressure line. Exactly, that we can draw labs from and we can monitor blood pressure continuously.
Okay, excellent. Our next question, when should families and or patients ring for a nurse?
When you need something that if you need a little thing, you can ring, but somebody might come back and say, okay, I'll be there and I can get to you just a minute because they may have another priority. Sometimes, maybe not a great analogy, but in some ways we're a service industry, right? So it's like the waitress coming to your table. Okay, it's like, okay, I need water. Okay, I'm going to get you that water. But if I needed to go somewhere else because somebody was screaming and there was a problem, I might not be able to get that for you right away. So if you need things, yes. If we can combine the things, just like a waitress, right? Well, he wants a water. Oh, well, she wants a water. Maybe it'd be best if everybody asked at the same time. So for those small things, if you think the baby's in trouble, you call for the nurse. The baby's vomiting, you call for the nurse. If something's wrong, you see something came apart, call somebody. Does that make sense? We want to be there right away for those kinds of issues. But just remember, it's just like anything else. And those of you who are in a service industry, think about it. The person who asks lots of littles, it may make it a little harder when you need a big. Okay? So just remember, as we each work together, we'd love to combine and work together to make sure things are okay and make sure we can all take care of things, if that's okay.
Yeah. Okay, so you addressed it a little bit, but families are wanting to know how they can feel more confident holding their baby who's attached to so many wires.
Okay, when they're attached to the wires and attached to the ventilator, a couple of things, okay? So you got to understand, some of the wires, it's okay if it pulls off, okay? Does that make sense? Like this one on my hand, pulls off, not a big deal, put a new one on, okay? Does that make sense? Okay. The little EKG wires, if they pull off, we plug them back in. Okay, so remember that. Ventilator tubes, falls out, big deal. Okay. IV lines, fall out, big deal. Okay. So when your baby has a lot of things, what we want to do is compact them. Okay. So sometimes what you want to do is get what you can within a blanket on a smaller baby, so it can compact, have things running out. So maybe we have a string of lines. So then you should be able to pick up. You always want to kind of scoop up. Does that make sense? Yeah. And have things kind of lay, but not pull. So the biggest thing is not to pull, and things that can pull that are okay, remember. Sometimes we even have we have these little clampies, these little green clamps. You can use those actually to clamp and run stuff through them. Does that make sense? And so that's another way to have everything kind of, what the goal is we cannot have, as you get better, things coming out in 6 directions. If we can somehow consolidate, it will make it much easier over time. And the less accessory items, the easier to pick them up and to do things. So you want to, but it is hard. But over time, somebody should be able to show you. You know what I mean? And make it easier. First times we're going to help you, but as they get better, more and more is you. You're right. Well, and like NG tubes, you don't want that to pull out. You know what I mean? So somehow run things maybe so there's not tension.
Okay.
It's really basics of physics. And when, you know, pick something up, have a lot of stuff falling off that, you're going to have a higher propensity to pull it out.
The nurses can help us, though.
Yeah.
So we don't have to be afraid to hold the baby.
Oh, no, we want you to hold because we want these babies to bond with you. I really am worried when sometimes the babies are here for a really long time and they're not held enough. Yeah, I mean, that we want that bonding to help.
Okay. Okay. Great. Any tips on making the CVICU more enjoyable for my child?
All right. For larger patients, I mean, toddlers and 6, 7, 8, 9, 10, personal stuff. Okay. So bring them some personal stuff. Or their toys, is there a toy they really like, a blanket they really like? Bring that in, let them have that, and let us know, you know, that this really calms them. Babies really like a pacifier. Okay, let's use that pacifier. This baby likes them. My baby never takes a pacifier kind of thing. Then let us know. Does that make sense? Over time on newborns, though, they want us to be careful. We love to decorate. We love to decorate and have stuff everywhere, but it's not safe sleep. So there's a whole thing, as you get better, we need to make a safe sleep environment so that all those toys wouldn't make it where your baby might get up against them and not breathe. So over time, you might see the bed get less and less stuff in it. And it's because of we're trying to create this safe sleep environment, meaning they want baby blanket, hardly anything.
Okay. Excellent. Okay.
But toys, bigger kids, iPads, iPods, you know what I mean? Child Life will help them too with a lot of those components and to bring things and to personalize. Yes.
Personalize it, reach out to
Yes,
Child Life.
Pictures are awesome. Some of the families right now have lots of pictures and those are awesome for us to see the babies and like, oh, they look awesome. You know what I mean? We can do hair, we can do clothing as they get better. We'd love to play dress up.
Okay, those are great, 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 great. Who is in charge of the CVICU?
Okay, you have medical and you have nursing.
Oh, okay.
Okay, so nursing is Alex Woodruff is the nurse manager. He's, I know, a large part of all the parent forums. So he's the nursing manager of the unit. So he's directly involved with the CVICU and the intermediate care unit, which is where we are actually today on the 9th floor. So he is there for nursing concerns and other concerns like you're not getting what you need, those kinds of components.
Great.
Medical, in charge is we have what we call intensivists. So an intensivist is a doctor who is specialized in intensive care, and these ones are cardiac intensive care.
Okay.
So the intensivist, who is the the director, is Sharad Menon. So he's the director, but always remember you can use the intensivist that's on that day for questions. Okay. But remember, intensivists and cardiologists are separate. So cardiology is another component. And you do always need to remember, I know it's frustrating to families, sometimes you may not see your own personal cardiologist while you're in the hospital.
Right.
It means he's not on service. But where he was seeing you in the clinic, that's probably where he is today. Does that make sense? So only one of them will cover, or two of them are on a week. So remember that people rotate. And in the ICU, we're 24/7. So the intensive care doctor is there 24/7. So you will see one during the day, and then you'll see a different one at night. And they don't work all the nights in the week. So even the nights, they're going to rotate. So just remember, you will see different people. But big concerns will go up to Dr. Menon. If you had to go on nursing even higher, the vice president of critical care is Kathleen Moore. So she would be even for a higher level of concern for nursing.
Okay, excellent. Quickly, where do I get a journey board? You mentioned journey boards.
You should be getting that from your nurse when you come in. You'll get a notebook, and the notebook should have the journey board. We want to hang it on the wall. It's really for you to update with the nurse, but you check it off. Like if you know stuff, you check it off, and there is an app that they have, a Phoenix Children's Journey Board app, that actually, as you open the app and move along, for those of you who are electronic, you can open up a lot of handouts in there. And then we also have the Emily Center. I don't know if you guys know of it. That is a health education library that will also help you if you need handouts, you need things about what's going on with your baby. They will help us also get literature and those kinds of things, especially if it's something unique. They'll help us a lot.
Excellent. Do you have time for one more question? One more question is rapid response. What is it and how do I use it?
Okay. Well, there's two kinds of rapid response. In the cardiac ICU, you'll see here something maybe called staff assist. So a staff assist is actually these buttons here. right there. I don't know if you can see, there's a code button, a staff assist button. So if there was something wrong with the baby, the reason the plastic is on it now because housekeepers used to set them off when they cleaned it. So you would hit the staff assist, and that would then ring to all the staff in the area, to their voiceras, and that we're going to come running. Okay. So that means I need help here now. Okay. For parent rapid response, there's a number. If you have concerns, that you can call that number and somebody will come right away for your response and your needs. Okay. So there's a family rapid response, and then there's also a medical rapid response. Okay. That we want people to come. So staff assist and rapid response are the same. So if you weren't in the cardiovascular ICU, but maybe you're up on the intermediate care unit, they have the same capabilities, and they would call it a CAT, or a clinical assessment team, meaning a team. They're saying, I need a team to come up here to this room right now to see this baby before something else happens, to be on top of it. So that's their piece, to get everybody to come to be there. Okay.
Wow. Okay. Thank you, Michelle. I have been in this room at least 3 times, and I've still learned so many new things today. So thank you very much.
You're welcome.
Thank you for explaining all about the machines, helping us take better care of our children as well. For our audience, please take 2 minutes to fill out this survey, asking for feedback on this event. Your insights will help to shape future events such as this. Also, you can find a recording of this webinar on Phoenix Children's Hospital website in the next few days, so please check back. On behalf of the Phoenix Children's Heart Center, Family Advisory Council, and Phoenix Children's Hospital, thank you for joining us today. We hope you found this webinar valuable, and we hope you can join future Heart Talks by Phoenix Children's Hospital Heart Center soon. Have a great day.